And then it's good to ask about the habits. Alcohol, understand that whatever the person says the amount of alcohol they drink is at least 3 times what they actually do. I mean, that's just how it is. What I like to do is give them a big, because they don't know like how much you drink. And so they're like, well, what should I say? So I give a big number. Okay, so how much do you drink? Like 3 cases? That's a lot of beer. No, it's just 2 cases. Oh, good. Because it's just what your frame of reference is. So it's really quite fun to kind of play this. And then, like, I'll listen to them, and they won't tell me what they're, that they're smoking, but you can smell the smoke. I can listen to them, and I go, Marlboro? I'm like, yeah, how did you know? Well, that's one of the most popular cigarettes. Well, I heard hoofbeats. So, you just kind of mess with them. But it's just interesting, it's just human. That's why I like medicine, because no day will be boring. There's always something going on and stuff. As the joke is, well, it could be something way too general practitioners. So also, just as a little aside, so I'm a family physician. I get a little irritated if you call me a general practice. The general practice, they haven't done a residency. Nobody knows. My wife doesn't know. So I get called GP all the time, but officially it's FP. Understand that as you guys go through practice, you want to be called what you are. And so if you want to find out how the doc and the provider wants to be referred to as, they're just very persnickety about that. So depending on what their specialty is, they're a little higher up. Neurosurgeons are by far the most uptight, because they don't even get out of school until they're 35. They're like bitter. And they do have brain surgery, life and death stuff. And then the 7 attributes of symptoms, there's a lot of ways to remember this, but where does it hurt? What's the quality? And the quality can be like, is it sharp or dull? Quantity or severity? Usually it's a scale of 0 to 10. And these days we're always getting looked at for our pain scale. And understand there's always 2 pain scales, at rest and with activity. So what's your pain at rest? Like low back pain, what's your pain at rest? What's your worst pain? And so you'll see that. Timing, I think, did I tell you guys that joke? So can you do me a favor? So ask me 2 questions. You guys say, would you mind going up with this? All right, so again, another dad joke. So if you can ask me 2 things. Ask me what's my profession and what's the biggest problem I have with my profession. So go ahead.
Okay, what's your profession?
I'm a comedian.
What's your
timing? So anyway, timing of when it happens, what makes it worse. Thank you very much for that. What's the setting? Is it only when they're doing certain things? What are aggravating factors? Like what makes it worse, what makes it better? And then any associated manifestations, like if it gets hot, then I get a rash, or if it gets cold, then things shrivel. That kind of stuff. And then past history. It's really nice. If you want to be real complete, go back to childhood. Like, how was your pregnancy? Did you, anything peripartum, preterm, or were you a normal? Like, did you have 40 weeks delivery? Anything like that. Especially if they're younger, you want to kind of know that. And then any childhood illnesses, I actually give them a timeline and kind of like tell me all this stuff that's happening. And then all the major adult illnesses. And then what are they doing to keep themselves healthy? Like, what's their health maintenance type stuff? Do you guys need chairs? Logan, so health maintenance practice, like, how's your nutrition, your activity, your sleep. Those of you that I talked to yesterday about quantum physics, how's your light environment, water and magnetism, so it's a little woo-woo. Family history, as like any family history of cancer, heart disease, diabetes, extinction. This is obviously a soccer player, Courtney. I'm kidding. I'm still trying to find a soccer player who can do a push-up. I'm kidding. So the other thing too is you just want to sort of try to prime their memory so that they can kind of remember all this stuff. Family history, at the very least, I always like their mom and their dad. Is your mom alive? Is your dad alive? If they're good, they just say, doing well. You might also hear about this abbreviation of WNL. Anybody ever hear that abbreviation? So WNL basically means within normal limits, but I joke that it means we never looked, so I don't like to use that one. But you'll hear people say those sort of phrases. But for genetics, we're starting to be doing more genetics, actual measuring, but at the very least, you want their nuclear family, like how's your mom and dad? Are they alive? And some people don't know their dad. Some people don't know their history. So you can just say that. But at least it's good to know that. Because like, if they have like, if their grandfather died of colon cancer, their mom has colon cancer, and they're coming in with rectal bleeding, like, that might be ding, 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 you know, you gotta make sure you're looking for that kind of stuff. So that's very helpful to figure it out. And then I do like to ask education, like, how far did you get to go in school? Like, if someone's like, you know, like have concussion, I need to know, like, you know, like how far did you go in school? And I would like to tell the story, because the theory is with concussion evaluations, I was in the NFL, that's all we saw, because they hit their head. The theory on the evaluation of concussion is that you're smarter than them. I mean, they barely, you know, went to college and didn't study. You know, most of them didn't like graduate. You know, they're bright, but they just didn't have the training. And so I would ask them questions and stuff. And you ask them, you know, relatively simple questions, okay? And a lot of them were like backward questions, like the days of the week backwards, or what's the months of the year backwards, or, you know, if I want to mess with them, I go, okay, cube root is 64, you know. And this one guy, he's had a concussion. This is playing, again, losing to Tom Brady. Actually, I think it's the first time he lost to Tom Brady. He was just a rookie. So this guy, I'm evaluating him, and he's pretty smart. So then my go-to is always, okay, name all the states around Colorado. And like, he like did it. And then he goes, Doc, no, I didn't tell you that. I'm like a super genius. Like, I try to hide it from the fellows. Nobody tell me about it. And it turned out, like, even when he's concussed, he's way smarter than me. And I said that, he says, D, and he's way smarter than all the PhD guys. He's now like a super agent, so he went to law school and all this because he knows football and he knows that. So there's no way to test him. Like, yeah, you got concussed. He knows he's not as good, but he's way smarter than me now. So it's just one of those educational. So if you know that they're pretty bright, you put that into play. You know, it'd be nice, family of origin, like, you know, what sort of nationality you're from. Interestingly, did I tell some of you about mitochondria? So 80% of our diseases can't be explained unless you learn about mitochondria. So some of you have heard about mitochondria, but it turns out mitochondria, what kind of inheritance does it have? Anybody? Maternal. So you really only care about your mother's inheritance and her lineage, officially. You'll always ask about the dad, but you don't know. But maternal inheritance is going to be more and more, I think, important. And then the household, like where do you live? Who's in the house? Just kind of get a picture. Do you live in a house? Are you homeless? Do you, you know, is it a nuclear family? Do you have children? I always like to know like where you went to high school. That's sort of my go-to. I know most of the mascots, and I'm trying to build rapport, especially if they're in sports. I kind of know who they're at and what they do. And then sort of their lifestyle, and that can be any number of questions. Review systems we talked about is basically a checklist of going through all of them. And so your provider will tell you, you know, it's non-contributory except for this or that. So, and sometimes you'll hear in the review systems, and we'll talk about the templates next week, that'll say non-contributory except per HPI. And so you'll see that phrase, so per the history. But I like it because then you're very compulsive, because if they, like I, you know, talked about, you know, different things, like there's something called a calcaneal fracture. Have you guys ever heard of that fracture? So there's 3 commonly missed fractures. One of them is the calcaneus fracture. So that's your heel. Again, heel is 1 syllable. Calcaneus is 3 syllables. So it's called calcaneus. Or calcaneal, that sounds even better. So that actually is called the lover's fracture or the Don Juan fracture. Because that typically happens in olden days when an armed suitor would chase somebody, a lover, out of the balcony, and he would jump onto the floor, fracturing his calcaneus. So they call that the Don Juan fracture, lover's fracture. And so it's one of those ones that, you know, when you see a calcaneal fracture, you need to ask them about their low back. Because imagine if you fell from height, and not all those fractures are lovers, they're construction workers. They always feel happy when I tell them that diagnosis. They have a lover's fracture. So when they fall, though, it's a straight column, and they actually get a fracture to their, typically like their L1 of their lumbar spine. So you need to ask, so if you have that, ask them anything else, any back pain? Well, you know, because that hurts so much, they might not even know. Well, yeah, it does hurt. And then you can x-ray and look like a star. So it's just good, I think, to be compulsive, to look at all the different things and just ask them. So now we'll get to the examination. And again, I sort of want to go through the logic the provider will go through as you're sort of, you know, coming up with what you're going to be out of the document. So this gets a little bit dry, but it has to do with how accurate the test is. And so this is what we as providers sort of go through. So the gold standard is actually to find out what's the best measurement for that. So biopsies for a lung nodule. So there's all these little cutesy phrases of how we're going to remember stuff, but one of them is tissue is the issue. Like today, I just got no one knows. So we've done a biopsy, it's positive, like we know that's what it is. So a lot of times that's what you're going to want is some sort of biopsy that you can look under the microscope. And then there's other different like questionnaires or exams, typical ones that you'll do like for ADHD, they'll have certain ones for like depression, there's going to be the PHQ-2 test, PH2 test, the PHQ-9, which is 9 different questions. So you'll see all these sort of exams out there, and you'll have to look at them. So this goes into a little bit of Bayes, predicted sensitivity and probability. I know a lot of you already have statistics. But understand that the test is only as good as sort of the pre-test probability and then the accuracy of the test itself. I do a lot of treadmill testing, so it does me no good to do treadmill tests on 22-year-old healthy young women that don't have any symptoms, because their chance of having heart disease is very low. Even if it's a positive, it's most likely to be a false positive. And the problem with doing tests on everyone, and this is another little phrase, actually from the House of God, don't take a temperature unless you want to find a fever. Don't do a test unless you want to find something bad. Because if you just say, oh, you have a headache, let's get an MRI, and now you find a cyst, well, is that from the headache, or is that just something that's going to be there? So you want to have criteria, because otherwise you're going to end up doing a bunch of other tests that may not be known, and you may cost that patient not only money, but also they might have to have an invasive procedure, that kind of stuff. So you have to be very discreet, and so you'll hear your provider or doctor talking about the specificity and sensitivity of the test and which one to do and which one not to do. So at least you'll understand why they're going through that. And it all has to do with Bayes theorem. You guys have had that, right? Bayes theorem. So the probability that person with a positive test really has the disease. And so this is what we fight for a lot. And then a negative predictive value is the probability that the person with a negative test does not have the disease. So a lot of times what I need to know is what you don't have. I need to know you don't have cancer. I need to know you don't have a heart attack. I don't know what you have. As long as I know what you don't have, then we can take our time and we don't have to do the full court press right away. And then a lot of it has to do with the pre-test probability. Like if you're, again, a young female, 22, her chance of heart disease is very low. Flip that around, say you're an 82-year-old guy who having the same, not really having symptoms, but at 82, even without symptoms, your risk of having a heart attack is a lot higher. So that tells you the difference. I did take a picture with my 100-year-old patient today. If you follow me on Instagram, you'll see it. And I can do nothing with him. He's 100. Like, he's good. He's got the worst heartburn. He's got all that. He's just a great guy. And he just comes in once a month. And the key is he married a woman 25 years younger than him, so she's only 75. And so anyway, because there's nothing he can't have. He's 100. So in that case, I desperately try not to order any test on him, because it's going to come back bad. And he has his medicines, and he's on like tiny, tiny doses of medicine. We call it homeopathic doses, just so he feels better that he's being treated. But I can't get him off of it because he thinks that's keeping him alive. And it's just the game you play in medicine. But it all has to do with pre and post test probability and life and all of that kind of stuff. Let me just cover this. So in general, you're going to be, depending on your situation, into a preventative situation or a reactive situation. So understand that there's different sort of recommendations, and we're really struggling with the guidelines. Those of you that know, I like the ketogenic diet and low carb, healthy fat, even though the guidelines say you should eat a lot of carbs. The reason, personally, is that I was on the high carb, low fat, running marathons, and I got a stent in my heart when I was 45 years old. Part of it was the stress of the frickin' Chargers trying to win. So we had to move the Monday night game one day and went bad on that. So bottom line is we need to change some of our intervention, and a lot of it is designed to prevent disease. Then there's what's called secondary prevention. If you already had your heart attack, So now you need to do a secondary prevention. And understand that what they're always going to talk about is what's called RCTs, randomized controlled studies. That a randomized controlled placebo study. So we sort of joke in medicine that we say, well, in my experience, that means you've seen 3. And in my series, that's 2. And then you can do a case report. But the joke is it's their end. So when you see a provider, they may go off track off what it is because it's all about personalizing for that patient. And then they're going to look at like how valid is the test. Sometimes the potassium will be elevated. Did they have high potassium? Or did that specimen sit for a long time? Because most of the potassium is inside the cell, remember? And sodium is outside the cell. So the typical sodium is like 135 or 140. The potassium is only like 3.5. And so there's like a 100-fold difference. If the specimen sits for a while, your potassium can go up. And so if the potassium is truly high, that could usually mean renal failure. But if it's just because it sat out, then it can just be because it sat out. So that's where they might repeat a test and that sort of thing. And so the challenge we always have is if you repeat a test, like, which one do you believe? Now I've got a bad one and I have a good one. And we sometimes have this instant happiness. Okay, it's good, I'm not going to change it, it's going to go with the good. But and we joke that we never check certain labs right before they're going to be discharged because something's going to go bad. So you'll see this, but the bottom line is they may talk about, even though you have this result, how valid is that? How good was my procedure that I did? Like if you're tapping a knee or doing a spinal tap and it's bloody, how valid is that? And does that actually affect what we're going to do with the patient? So again, we sort of say don't do a test unless you're going to do something with it. Like everyone who comes to see me, no matter what boo-boo it is, wants an MRI. I'm like, fine, oh, you want surgery? Like, no, I don't want surgery, I just want to know what's going on. Well, I can tell you, and that's where the trust comes into play. But understand, we do an MRI mainly to think, do you need surgery or not? And there's a lot of people in pain that have normal MRIs because MRIs don't show pain. So you sort of have to go with this with the patient. So as you're kind of deciding what tests to do, my opinion with you guys is be active. Kind of as you get going, think about what you might want to order, and then when the doctor or provider orders it, if it's right on, then you're good. If it's not, like maybe say, hey, why didn't you do this or do that? I'll be frank, as a provider, I kind of like that because like maybe you're seeing something I don't see, and then we're as a team, like that whole pit stop, we can kind of like help each other. And for you, it's not boring, but you're going to learn something because it's all about making mistakes. Because in medicine, we sort of have this procedure of 3, like see one, do one, and then teach about it. My joke is see one, do one, miss one, and teach about it. So you kind of want to be wrong a lot when it's not your responsibility, and then figure it out. But this is a good way, and I think this is the best thing about being a scribe in terms of going to med school, and why, like say, Tanner, you saw last week, does really well in school, because I've kind of been, I'd like to think, educated him, frankly, yelling at him when he's wrong and what we do, but I want him to be wrong a lot, so that when he's really with patients, he's not going to make a mistake, and that's kind of what we're doing. And understand there's bias, so certain people, you think that they have it, they want to have it, and so there is selection bias as to what you do. And a lot of things, many of you know about Rancho Bernardo. You guys have heard that city, right? That's where all the Caucasian studies were done, because before I went to med school, Rancho Bernardo was this enclave of Caucasians. And they did all like the lipid studies and hypertension studies. And then there's Ashkenazi Jews that are in New York and that subset. So there's all these little enclaves of different things. And a test done on a certain population may not be the same as another population. And so they look at that. So there's a lot of bias in the different tests that you do. And then there is detection bias, like how well are you able to come up with that outcome. And then attrition, a lot of times, people just, they just didn't have enough to say, and they just, a lot of these tests, what was the one I just heard about? It has an amazingly low number, and we base everything in medicine on this like 35 people and stuff. So you're going to see more and more of that coming out as to how important is this test and how well they do. And then one of the things I like to do is what gets measured gets managed. So I have people, for example, have cholesterol problems and their HDL is low. So the HDL is really the critical one these days, not the total, but the HDL and the triglycerides. And if your HDL is low, that's kind of how long you'll live. The higher that is, the better. The problem is we have no medicine for that, so that becomes lifestyle. But I have some people where I'll just give you a standing order for once a month, get your cholesterol checked. And because of electronic health records, they can just check it online. They don't necessarily have to come see me, and we can just see, do everything you want and let's measure it. Do anything you want, measure it, we'll kind of see what. So you'll see us doing measurements to see if they're being effective. You were anemic when you came in, we gave you 2 liters, or we gave you 2 units of packed red blood cells. We'll check another lab, see how you do. The problem is, let's say you got a gashing wound and you bled out, say, a liter. You only have like 5 liters in you. So you bleed out a liter, which is a lot of blood, and you do what's called a hematocrit, what percent of your blood is red blood cells. It could still be normal because it didn't have time to dilute out. So that's where you're going to see a lot of people talking about the effectiveness of when we do tests and what they do. But I think for you guys, you want to get the big picture of doing that. And then you want to know, generally, does what you do kind of fit for the people that you're seeing? And you really have to look at the benefit versus the harm. So a lot of times, there are some tests we just decide, we don't want to do, and we have to decide that. For example, if you have a cough, the chance of you having pneumonia is very, very low. You're a pregnant woman, like, do I want to radiate you, possibly hurt your baby, versus possibly miss a remote pneumonia? So the obvious answer is no. You sound good, it does okay, I don't think I need the x-ray. So you look at that benefit, the risk-benefit ratio, you'll see that a lot. So I'll tell you what, why don't we take like a 5-minute break just to give you guys get some fluids. So we'll come back at 5 till.